get started. So thank you guys for coming to our committee meeting this month, or this quarter, I guess. We'll go through the agenda really quick. So we do have our guest speaker through Vivint Health, Ben, here. So we'll introduce him in a moment. We'll review our average daily census, Project Fusion, social determinants of health, give a brief infection prevention update, do our normal CPI move of the meeting, introduce some of our new employees, welcome them to the team, and we had some employees pass their NCLEX, so do a little shout out there. We'll talk about improvement huddles, releases, net promoter score, labor management, Civilitas, culture of safety. Danielle will touch base on an RCA, so a root cause analysis that we had completed. We'll talk about readmissions, and then at the end we usually just do our random updates, so therapy updates, case management updates, unit updates, and then just general teamwork at BPC. So that's the agenda for Civilitas. That one is a video. We always kind of play it by ear based on how we're doing for time, whether we play the video during the meeting or if it gets sent out after. So that one we'll just kind of see how we're doing time-wise, but we should be able to get through everything. So with that being said, I will turn it over to Ben, again with Vivint Health, and he will explain what Vivint Health is, what they do, and everything like that. So we appreciate Ben's time today, so I'll turn it over to him.
Thank you. Yep, my name is Ben Brusso. I'm a prevention supervisor at Vivint Health. I'm not going to stand just because I'm getting over the flu, so I don't want to pass out on you, but this is the room to pass out on because everybody can take care of me after that. So I'm here today to talk a little bit about our prevention services in specific, but a little bit about our agency overall. Vivint Health is essentially, if you're familiar sort of with care providers in the area, we were formerly known as the AIDS Resource Center of Wisconsin. And so we are a sort of the new vision of ARCW, which has a really long history here in Green Bay specifically. But we have merged with a number of different organizations that serve folks living with HIV or who are at risk across the nation. And so that is kind of where Vivint Health came from. A little bit about our name. Viv is to live in Latin, and then ent is the sort of the verb for prevent, and so that's kind of where Vivint gets their name. And so, what is Vivint Health, or who are we? We are essentially, our goal is to see a world without AIDS, right? So we envision a world without AIDS, and we strive to ensure that everyone living with HIV has a long and healthy life. Our mission is to be a relentless champion for people affected by HIV and do all we can because we know that everybody has value and deserves respect and dignity. And people are essentially at our center of what we do and what we do to help communities. So Vivint Health operates what's called an HIV medical home, and so there's different medical homes you may be familiar with, right? So typically a medical home surrounds a chronic illness or disease, and we operate an HIV medical home. So we have all of these services co-located in one space to ensure that there's communication, ensure that patients are getting access to all these services without having to go through barriers. And so in our Green Bay location, we have everything that's up here except for our in-house pharmacy. But essentially our larger locations like our Milwaukee area office, our Madison office, all of these services are located in one spot, and each of the providers in all of their areas work for Vivint Health. So we're not volunteers coming in and doing providing care for our specialty. We're all Vivint Health employees, and we're all talking and discussing to make sure that the system works. So we have primary medical, dental, and behavioral health care therapy. We do specialty HIV care, and we do primary care. We have psychiatry, therapy, and AODA drug treatment in-house. We have a full range of dental services, so pretty much everything except for tooth surgery we can do in-house for folks living with HIV. And then on the the right side of the screen is sort of all of our social services that we have for people living with HIV. So we have legal to help folks who are going through like unjust situations like discrimination for housing or discrimination for social security, insurance, case management and insurance navigation. We have a ton of different housing programs that help folks get into housing or retain housing. And then our locations all have food pantries and nutrition access. And so you might be asking, so why are all these services in one space for people living with HIV? And really what we want to do is we understand that the HIV care is not the hard part. It's really getting people to the point where care is not such a huge thing to access, right? It's this battling the social determinants of health that so often many people living with HIV face, right? Somebody's not going to take it's easy as one pill once a day to retain regular HIV care, but folks who are unhoused are not going to take their medication when they don't even have a place to store it, right? And so that's really what our agency does. The other unique thing about this model of care is that if somebody goes in for a tooth extraction, let's say, their dentist can see if they're accessing the food pantry, and they can call over to the food pantry and say, hey, this patient is having a tooth extraction today. Can we make sure we have soft foods available that they can take home that day so that they can eat, right, and get nutrition, but also that the medications aren't going to be interacting, and they can achieve that overall health. So it was created in 2011. Our agencies have been around since the early, AIDS epidemic in the late 80s and early 90s. Our HIV medical home is recognized by Medicare and Medicaid, which means we can reimburse for those services. And then the health care outcomes speak for themselves, right? Durable viral suppression is essentially the suppression of HIV in the body, right? We still have HIV, however, if you can suppress the virus down to the levels where it doesn't even show up on tests, you can't infect another person, and you're retained in that regular care. That's really the gold benchmark. Typically across the United States for different organizations that serve people living with HIV, it's around 80% is sort of that benchmark. More than 92% of our patients have achieved that durable viral suppression. Racial disparities in viral suppression have ranged differently in different parts of the nation, and our patients, we've gone from 14% of a disparity to less than 6%, and in some locations we've actually eliminated that racial disparity because of the different access and support services. 94% of our patients are retained in at least regular care, which is at least every 6 months they're seeing a doctor. And then almost 100% of our patients have been prescribed some type of antiretroviral for HIV. A little bit about how many patients we're serving. So we serve about 2,500 people living with HIV in the state. And then PrEP, which is the pre-exposure prophylaxis, so the prevention drug that folks can take one pill once a day. We serve almost 700 folks living who are at risk for HIV who take a pill one time a day to prevent an infection. CMS, Center for Healthcare Systems Research, found that because of the unique model of care and the support services people are engaging in, our patients see 52% lower hospitalization, almost 50% lower unnecessary use of the emergency room as a primary care source, and then 10% shorter hospital stays as well. And then the other sort of benefit to this care model is that our patients are engaged in regular care. They're not having to access emergency care or unnecessary care systems, and we save about $4 million to the state Medicaid program annually because of the care model. So that's sort of the overview of our agency, and really the meat and bones of what I'm going to talk today about is our prevention services program. But did anybody have any questions on our medical home or the care model for HIV? Awesome. So I'll get into our prevention services, which is the department that I'm in. We are across all 72 counties in the state, based out of our 10 offices regionally. We have offices in each of the locations here where folks can access our prevention services or our care services as well. And these are the different interventions that we provide. So our prevention services department, we really work with folks who are at most risk for HIV. And sometimes that could be that when we consider like higher risk participants for HIV could include like LGBTQIA individuals, folks who are men who have sex with men, or people who inject drugs or use drugs in a certain route. And so our interventions that we provide to prevent HIV really revolve around the certain behaviors that individuals may have. So we provide counseling, testing, and referral, condom distribution, our LifePoint program, which is actually what I was asked to kind of talk about today. Outreach, prep, and then some prevention, navigation, and research as well. So all of our, everything that we do at Vivint Health, including our care model and our prevention services, are really rooted in the harm reduction model of care, which essentially identifies an individual, recognizes that they have a certain behavior that may be considered risky in some aspects, and it looks to minimize the effects of that behavior rather than condemning or ignoring them, right? So we're saying, we're meeting you where you're at, we're recognizing that you use substances, for instance. We're not gonna tell you you can't have care or that you need to just stop using, but what is something that you can do differently that might improve your health in the long run, right? So that could be like our therapist saying, you know, what does better look like for you, right? Does that mean like maybe instead of using 6 times a day, you can inject only 5 times? Or does that mean rather than using a used syringe, accessing sterile equipment to inject drugs? So our counseling, testing, and referral program, we offer it statewide. Essentially, it's free point-of-care rapid testing, so it's just one finger poke. We get the results in 20 minutes. We do that for HIV, hepatitis C, and syphilis. Hepatitis C being the #1 bloodborne pathogen in the United States. Our folks who inject drugs are there's a 50% likelihood that people my age at some point in their life will contract hepatitis C if they inject drugs. In our Milwaukee and Kenosha clinic, we also offer chlamydia and gonorrhea testing. Just want to mention this as well for folks. We have an online store where folks can go online and they can actually order at-home HIV tests, condoms, and now naloxone that we ship directly to their house, free of charge in discreet packaging. So across the state, in 2022, we provided 2,390 in-person HIV tests and almost about 2,000 hepatitis C tests and syphilis tests to participants who are at most risk. This slide is just showing sort of the bounce back from COVID. We had a dip obviously in our service lines because we were in person. HIV infections across the board, especially in this area, they've sort of waned. So we've seen lower infections in certain populations, but then increased infections, or rather, lower infections overall, but increases in certain populations, right? So, especially after COVID, because there's lack of access to testing, people might have had to put themselves in situations where their risk did increase to, secure housing, or there were dangerous situations people were put in. We have seen a slight increase in certain populations, but still overall infections have trended down. Condom distribution is another one of our programs. We distributed almost 475,000 condoms across the state in 2022. We have really great partnerships with a lot of organizations in our area to get condoms out there. They can come to our offices and pick them up. We've got bars in the area. We work with tribal health clinics, health departments to just make condom usage something that is not so taboo, not so funny to talk about, and ensure that there's access. There's a big gas station chain that does not sell condoms at all, if you notice, and so a lot of condom access has been such an important thing because people don't know where they can go to get them, that they're not so expensive. All right, our LifePoint program. I was asked to talk a little bit more in depth about this program. And so this is one of our oldest standing programs and sort of the one that's the most used by volume. And this is our syringe access program. And so the goal of this program is to reduce the spread of HIV and hepatitis C amongst people who inject drugs or use drugs in different routes as well. It's conducted in the office. We have outreach sites that we provide this at, and then we do mobile delivery services as well. And essentially what it aims to do is provide sterile equipment to inject drugs rather than folks putting themselves in a riskier position where they may contract HIV or hepatitis C or other bloodborne pathogens, skin and soft tissue infection prevention, by providing that sterile tool to use drugs. What we know is that through this program we've been able to reduce the amount of HIV in the state for injection drug users by upwards of 90% when we provide them a tool to inject. It does not increase drug use, it does not promote drug use, it just essentially lives in that harm reduction model of we recognize that you use drugs, we know that you deserve dignity and respect, and we know that this is a temporary situation, right? And we don't want you to have to live with HIV the rest of your life because we can provide this syringe for you to get you through to the next phase or whatever better looks like for you. With that comes a really great access point where we can meet people where they're at, provide them referrals to treatment, referrals to mental health care, overdose prevention, and we've been able to do a lot of really great things in this space. So here's an example of some of the tools that we do provide to participants. All of the materials here, we cannot use federal funds to actually provide these tools, so we self-fundraise for all of these. Everything on the screen is used for some form of disease prevention. So the strap, we make sure that folks have access to tourniquets because then they're not going to roll veins, they're not going to miss shots, they're not going to get abscesses, they're not going to get blood infections. We're seeing a lot of folks not so much get sick from overdoses and die. We've had a number of folks who have gotten bad infections that have gone to their heart and they died in the ICU. I know a couple of my clients have unfortunately passed that way. So something as simple as a tourniquet can prevent all that for somebody. The cookers, the 2 metal tins, those are used to cook and mix prepared drugs. Hepatitis C can live in one of those for up to 3 weeks. And so rather than them putting themselves at risk for getting hepatitis C, we can provide that cooker to them. The cotton is used to filter particulates out of whatever you're injecting. Something's got to be in a liquid form to inject. But the cooker or the cotton helps filter out what may be in there that doesn't dissolve, so that they're not getting issues with their veins at all, right? So when they're injecting, they're not getting those hard materials into their veins. And then alcohol wipes obviously prevent any bacteria on the skin. So here's a list of sort of some of our satellite sites we partner with across the state. We know that we can't access everybody and that access is an important thing. So we work with a number of health departments, a number of community-based organizations, recovery centers to really promote the messages of harm reduction and making sure that we're getting these materials out there to individuals. So in 2022, we distributed more than 4.6 million sterile syringes to participants in Wisconsin. Part of what we do is we want to look at community care and understanding what are the effects if we don't have a safe place to access or dispose of syringes. And CDC studies show that programs that have, or communities that have these programs in them are much safer, right? There's less syringe litter out in the community for people, right? We're not seeing so many syringes found in parks or on the sidewalks because there's a safe place to go and dispose of these. And so we see this number that says 1.6 and that's not 4.6. There's a number of places our participants are more informed. They know where they can go. They're provided sharps containers. and some of our folks are rural, so they just burn them, but there's a number of reasons that those two numbers don't match. It's an anonymous program, so we don't know how many people individually we actually served, but we provided more than 25,000 encounters in 2022. And then, like I said, a big part of the program is the referrals and helping folks get the services they need. And so in 2022, we provided almost 415 drug treatment referrals to individuals, 145 human service referrals, insurance enrollment, mental health services. And so because there's a safe place where people can move past the fact that they use drugs, right? That's why we know that they're there. We can really help them try to navigate whatever types of services they need from that point on. So one of the other things we do is overdose prevention. So we have been giving out fentanyl test strips for almost 6 years now. And if you're not familiar with fentanyl test strips, they're a tool that basically allow you to test what you're using for the presence of fentanyl. We distributed almost 53,000 strips in 2022, and for a number of reasons, we don't always get the report backs, but we got about 3,500 report backs that were tested positive for fentanyl in our communities across the state. So, I don't know if you can see the null on the bottom. Ooh. So essentially these are, each one of these bars represents sort of one of our offices. I will say the Green Bay bar is, I think, the middle one here, this gray, this one right here. And so these are positive report backs. I will say, I wish I could see the number there. Anyway, look, the Appleton one is the one on the far left, right? That number is staggering. We got almost 1,300 report backs just from that office alone that were tested positive for fentanyl. You can see that the type of drug that people are ingesting, it does not discriminate against. The red is positives amongst heroin, or folks who are using heroin, so they tested heroin batches. It's about 50% heroin and meth in the Appleton area that's testing positive for fentanyl. The one right next to it is our Beloit office, and that one's always very interesting because they have such a high percentage of folks who are testing their cocaine and it's coming back positive for fentanyl. So it's not even drugs that are typically, like there's the big four here, right? But, and sometimes our folks who use cocaine only, it's like, well, I don't inject, I'm not chaotic use like the folks who use meth or heroin or whatever. It's more of a party drug or a weekend drug. But those folks are also at just as much risk because they may not have access to those harm reduction messages that a lot of our folks who maybe use more often or have more chaotic use do. And so that's why it's important that communities know how dangerous fentanyl adulteration can potentially be. The good news is that out of all the folks who tested positive, or the folks who tested their drugs positive rather, everybody made some type of behavior change once they knew that their drugs had fentanyl in it, so that they could be safer, right? So that could be pushing the plunger and kind of tasting the shot, seeing how it felt, and then deciding if they're going to use the drug or not after that. It could be that they threw the drug away. We did have a number of folks who just said, I'm not messing with it, I'm getting rid of it. We had a number of people who would return it to the dealer and say, like, this is not what I wanted. And so it's good to know that folks, we know that folks don't want to die, they don't want to have fentanyl in their drugs, they don't want to become addicted to fentanyl, and they'll do something differently to make sure that they stay safe. One thing before I move on to naloxone is we are starting to distribute xylazine test strips, and I'm not sure if anybody knows what xylazine is in this room, but it's essentially an animal tranquilizer, essential nervous system depressant. We've been seeing it cut into a lot of substances. I think that the opioid overdose epidemic of like 2020, it continues to grow, but I mean, they're starting to see that xylazine was cut into substances as far back as like 2018, 2017, and so I think they just weren't looking for it, unfortunately. And so we have strips that folks will be able to start testing their substances for xylazine as well. Naloxone, everybody in this room know about naloxone, how to use it, familiar with that? Okay. So we distribute naloxone in a few different forms. We use IM and nasal. Nasal is more for our community-based folks, organizations, and then our clients we distribute intramuscular because it's much cheaper and it's a little less. It provides a little less precipitated withdrawal, right? So it's an easier comeback, which we're hoping will not push people to want to use again right after they get rescued from the overdose. We distributed about 61,000 doses of IM and 4,600 nasal kits through a bunch of different trainings. And then we ask our folks when they get a new kit if they've used it on anybody, and we had about 2,146 peer saves. That's folks who are in the community using it on their peers or people that they love, and it just shows the importance of naloxone and having that out there in the community. How am I doing for time? Good. Okay. Does anybody have any questions on the LifePoint program before I move into research and some of our other programs? LifePoint is free of charge. It's anonymous. Anybody can access at any point when we're open, and they can use the program as long as they need. Right? There's no. It's rooted in that harm reduction philosophy, so there's no requirement for them to move forward on some path of changing on that spectrum of use. We recognize that harm reduction is recovery in a sense, and that it's a change on that spectrum for the better. And so sometimes we'll see folks a couple times, and sometimes we see them over the course of a couple of years, but each time we plant a seed of how you can make a better change each time. One other thing that we do is with our harm reduction programs is we engage in, we have a really robust, unique prevention research arm in our department. And so we work with academia to sort of study how we can reduce overdose and HIV amongst populations of people who inject, specifically rural communities outside of Madison and Milwaukee. So we have a couple different studies here. Thrive for Life was a rural opioid initiative that's been a 6-year project through the NIH and working with Dr. Westergaard from UW and DHS. We engage in OD2A, which is the Overdose to Action Program. There's a number of communities and folks who do OD2A grants. And then Project Nexus was a project with UW-Washington, or UWash out of Washington State. Rural Opioid Initiative wanted to study folks who inject drugs in rural communities, and then the second phase was really it was providing an intervention to essentially create a unique model of intensive case management for people who use drugs to help them achieve the goals that they wanted to achieve. So we enrolled a ton of people over a couple of years in our 6 northern offices. We provided focus groups. We did a lot of interviews, one-on-one with folks. We paid participants to come in, get a survey on an iPad, and then get tested for HIV, Hep C, and syphilis. And then we asked them to come back in 6 months and do the same thing, and then refer people in their networks. This study was really, really awesome. We were able to genotest hepatitis C, and we found like networks of like how infections spread by the genotype, and we saw like the networks and how people use drugs and how they connect with each other. It was fascinating to see somebody who was infected in Brown County. That particular infection traveled all the way up towards Superior through communities and networks of people who use and unfortunately shared equipment. And so so that's why it just proved how important this work is to really stop the spread of that communicable disease. What we learned in our first phase through these studies was that 72% of people feel ashamed using drugs. No surprise there. Shame kills more than fentanyl does. 66% of folks thought that people avoided them because they use drugs. And you can just kind of see where people were at as far as when they were surveyed, what their perceptions of themselves were because they use substances. This bar chart's a lot to read, but essentially it just shows a strongly agree to a strongly disagree. And these are how easy it is to access resources. And so you can see down at the bottom, most felt that they could easily access condoms because they were in a place that provided condoms, which was our offices. And then you can see sort of the things that we didn't necessarily offer, or maybe were less accessible in their communities, which was like MAT. You can see 25% only felt that they had an easy access to MAT or methadone. So then we took all that and we said, all right, let's create some type of intervention that can help people work on these goals and increase access. And so that was our community-based client-centered prevention home, which I'll refer to as prevention navigation. It was supposed to mimic sort of what our case managers do in our HIV medical home, but for folks who inject. We wanted to make sure that people increase their knowledge about resources, but also had access to those resources and reduced barriers. Short-term intensive case management is basically what we modeled it as, 90 days. They would meet with their prevention navigators I believe 6 times, and they would create an individual harm reduction plan to either just to try and reduce overdose, but then work on their other goals, which could have been like, I want to get Hep C treatment, or I want to get into housing. So these were basic needs at program entry. You can see almost everybody had a priority basic need of mental health or income, or a place to sleep. And so what we saw after that 2-year study with folks who were engaged in the prevention navigation was over 53% reported that they had a better met need of a safe and stable place to sleep. They had a better 35% had more increase to food for self and family. And then you can just kind of see that the study proves that people can have increased access to these resources or betterment for themselves when they were engaged in this model of care. 22% of our patients reported that they had increased confidence in accessing substance use treatment, and 18% said that they had an increased likelihood of accessing the preferred substance use treatment option after participating. 24% said that they used fentanyl test strips more often, and then 85% said fair or complete confidence in ability to access sterile equipment for injection use. OD2A was a smaller, sort of mimicked the larger scale project, but it was just in the southeastern and south central part of the state. And then Project Nexus was a project that looked at surveying participants in our Madison location to understand what barriers they faced. Some shocking things that we learned was more than half of folks reported that they used alone, which is obviously very dangerous. We don't want people to use alone. 4 out of 5 said that they had revived somebody with naloxone in the last 6 months, and 1 in 3 accessed substance use treatment in the past 6 months. We saw increased access from this program because it brought new people in. 69% of increase in our programs, and then we had a 160% increase in the number of folks testing for HIV. And so research is a really awesome thing. It gets communities involved, and it gets not only gets the voices amplified, but it involves new folks who maybe have never accessed our programs before. And then we have a bunch of new programs. We're actually engaged in 2 different research programs right now. One is iThrive is actually over. That was providing cell phones to individuals to basically provide check-in for overdose prevention tools on a daily basis. And then our Enhance project, which is focusing in our Green Bay and La Crosse and Madison, Milwaukee areas, creating a leadership team of people who use drugs to drive future prevention research. And then our PrEP navigation essentially models both HIV case management and our prevention navigation, but it creates navigation programs for folks who need access to our 1 pill once a day prevention tool. You can see that this tool has grown. We know that PrEP is very highly effective in preventing HIV, upwards of 99%. However, folks who need it the most, who are at most risk for HIV, may not know how to access HIV healthcare or how to access traditional models of care. And so prevention or PrEP navigation helps people get through those barriers. It helps them work through financial barriers or insurance enrollment. And so it has been a small program that has grown to a national program for prevention, for PrEP navigation. And then we do a lot of fun outreach that stems really from where HIV prevention outreach grew from, which is outreach to LGBTQ communities. We go to Pride, we do a bunch of different festivals in the summer, tabling, doing games, handing out condoms, and working with community. And then we do a lot of harm reduction events where we table and provide Narcan trainings and materials distribution, and we work a lot boots on the ground within communities. And then this is one of our things in Milwaukee that we do every year at Pride. We do a vote ball. And then this is just a list of the number of individuals we reached through all of our outreach. So we really appreciate what we can do in communities and better serve them. And that is all I have, actually. Any questions at all?
Yeah. Any questions? All right. Thank you very much.
Yeah, absolutely. Thank you.
I know Marina had been in contact with Vivint, is kind of how this all started, and she was able to get some brochures and information. It was passed on to their case management team. So
yeah, and I brought some too, if anybody's interested in sort of like kind of a more in-depth overview of our services. Certainly if you're working with anybody living with HIV, all they have to do is just, you or them can just call us, and we really make sure that we are on top of referrals to get them into care or help them navigate whatever that may be. Somebody doesn't have to necessarily use all of the services. They can use, we allow clients at the center, so if they only want to use our food pantry if they're eligible, that's all they have to use. Or if they want to get dental, they can just use dental. And so we allow that up to them.
thank you for bringing that.
I just have one question.
Yeah.
Is this the same as like ARC, the AIDS Resource Center? Is it the same program? Is it a different program? Is it combined?
So we are ARCW, but ARCW was sunset, and so we're Vivint Health now. And so the reason it was sunset is there's a lot of stigma right in the name. Like we would have clients who would not come to us because we had AIDS in our name. Or we used to have a tablecloth that said AIDS Resource Center Wisconsin. People would literally look at me and be like, ugh, and they'd walk away. And so that's just, unfortunately, there's so much stigma there. We are also kind of moving past, really, it sort of was stigmatizing. We were stigmatizing living in that space, right? Not that people with AIDS or anything like that, but it's people with HIV, they live long, healthy lives, and so when we said AIDS Resource Center, it's such a historic name that it was almost like we weren't allowing ourselves to move into the future, and that's when we changed the name. Good question, though.
All right.
Awesome. Thank you,
Very
everybody.
much. Thank you. And then Ben, Stacy will bring you back up
Oh,
to the
sure.
front to let you out. Thank you so much.
Yeah, you guys enjoy your staff meeting.
Thank you.
Thank you.
All right, so now we'll just kind of go into our normal agenda. Yeah. All right, so we're a little ahead of schedule, so that's good. So average daily census, this is the graph that we show pretty much every team meeting, just to kind of show you guys where we're at. It's really interesting to see, so for March, so far, March isn't over, but we are exactly on target to where we have been the last 2 years, actually. So for some reason, March really, we kind of maintain that same census. So, as you guys know, we've been higher census this week. We've kind of been up and down periodically. So just something to keep tabs on and kind of compare as the year goes on.
So this is me. So Project Fusion, so most of you, has everybody heard about what Project Fusion is? Okay. So Project Fusion, the kickoff for this is going to be in April, with a plan go live in July of 2025. So our enterprise, so us and Gunderson, we've met and decided that we'll be moving forward with the Epic Behavioral Health module. So that will be new for both service lines, so to speak. So we will be working to basically build this kind of from the ground up together. So the new version of Epic will be both Gunderson and Bellin will implement with a goal to use as many Epic Foundation workflows as possible. So Epic has like a basic recommendation that they have built in. We've spent a lot of time kind of trying to retrofit our behavioral health workflows inside of a primary care driven or like a medical version of Epic. So now we will be moving into a version that will be behavioral health focused. Care plans will work smoother, treatment plans will work smoother. So it really should be a big improvement for us. We're really looking forward to it. And along with this does come a part of Epic that will do 15-minute checks on iPads. This is a possibility that's part of this. We're kind of at the process where we'll decide whether or not we will go live with that at the same time in July of 25, or if we'll wait to do that another time because it will be a lot of new stuff kind of all at once. But for Project Fusion, the inpatient representatives are going to be myself, Pam, for therapy, Dr. Wanamaker for the providers, and then we will be obviously working with case management for any behavioral health specific items as well. And then frontline staff will be asked to participate to provide any inputs on various portions of the project because we are hoping to work with Gunderson to find ways to be doing the same things. Obviously, we do have different settings. We are a freestanding psychiatric facility, and their psychiatric unit is considered part of their hospital. So there will be some things from regulatory standpoints that will be a little bit different as far as documentation and requirements, and we recognize that. So we'll be working through some of those things. So if anybody has any interest in being a part of any of this work, just let myself or Pam, Dr. Wanamaker, just let us know if you're interested, because I'll definitely be reaching out, because obviously I don't use it all the time, and so I'll be looking for obviously input from those of you who do the work every day.
It's a super fun group of people, so if you have any interest, be in good company.
That's me. I didn't know the order of the slide.
That's okay.
So, okay. Hi, everybody. I don't know if you remember me, Tony Weiss, team leader for case management. So, what I wanted to chat about a little bit today are, sorry, standing in front of me.
Come right
You're
up.
right.
Yeah.
I don't
Take
like
the
standing in
stage.
front of groups. Okay, so social determinants of health. And you can read the slide, little backstory, but what I wanted to share was social determinants of health is a big priority for the system. It always has been, but right now, because CMS is requiring us to ask certain questions about patient social determinants of health to meet particular requirements, it has now become a really, really high priority. And so what we're gonna be doing is working on some standardization. So this is happening at all Bellin hospitals, BMH, Oconto, and here. Trying to make some standardization so that everybody knows what their expectation is and what questions do I have to ask, what am I obligated to do, what type of resources do I need to give to the patient when they identify a concern. Maybe it's a transportation concern, maybe it's depression, maybe it's food insecurity, whatever that looks like. We're gonna come up with some standards so it's very straightforward and easy for staff to know what do I need to do when these things come up. So we have certain folks that are gonna be asking the questions. Currently, and I'm not saying this is the way it's necessarily gonna be, but it's often a group effort. So nurses are gonna be asking some of the questions, therapists are gonna be asking some of the questions, case management might be asking some of the questions, and then once we have those criteria put together, if a patient identifies positive, there's going to be standard resources that we're giving out to the patient. So we're trying to make it as easy as possible for staff, so you don't have to do a lot of interpretation, but again, make it really easy for us to identify those needs. If you're familiar at all with the longitudinal plan of care, that is a tool in Epic, and if you haven't seen it before, look for it next time that you are in Epic, but you will see an identify wheel that looks very similar to the one that you see on the screen. And when we ask the questions of the patient, items that identify as positive, which could be negative, okay, so if they're saying, yes, I have, depression or financial concerns, etc., they may turn red or they may turn yellow depending on the answers to the question. We will have identified resources. If you do have a red, for example, let's say in alcohol, for example, there will be identified resources that we are going to want to give to the patient as part of their ABS for them to take with and refer to, as well as possible contacts, etc., etc. So this is a preview. Just letting you know the process is coming. It will be additional education provided to everybody. Again, we want to make it really very clear. It's hard when it's a little black and white, right? Like, am I responsible for this, or is somebody else going to do it? So that's something that we need to work through a little bit closer. Working heavily with the quality team because they are kind of the overseers of this across Bellin-wide and making sure that we meet all these requirements. So if anybody has any questions, I'm going to be working with these ladies, all of you, in determining what that process looks like. So next steps, just so you know, we are in the process of gathering those identified resources to make it a very easy transition for everyone. We'll identify who asked the questions and then what needs to be given. So preview, more to come. Did I miss anything? Okay. Awesome. Does anybody have any questions? Okay. Thank you. Yeah, you bet.
Infection prevention updates. So Christine worked nights last night and she works nights tonight, so she could not be here. So I will cover this slide for her, and then if you have any additional questions, we can try to answer, or Christine will be your go-to girl. So she shared that there recently have been some questions regarding what precautions are required for patients who have a history of MRSA, ESBL, or other multi-drug resistant organisms. So she met with Megan, who is our system infection prevention person, and they looked together at our policy and just wanted to kind of clarify some things. So based on that policy, it states the following. So the recommendation is to treat them as colonized with modified contact isolation. So this would mean that staff do not need to use a gown and gloves when in the patient's room or providing care to the patients. However, the patients must still follow the 5 C's, and that's on the next slide, so I'll get there. For active MRSA, contact is required. And then for patients with a history of MRSA, but then they also have now an open wound of some sort, we have to make sure that we're consulting H&P or the attending provider and kind of work through if it's active or not and what that would look like. So there's a lot of words on this one, and my eyesight isn't the best. But on the left-hand side, you can see the 5 C's. So as long as we have a patient who can be compliant with the 5 C's, this is what we're referencing. So they have to be competent and understand the directions. So if you tell them to do something, to wash their hands, they have to be able to understand and recognize that disease process. They have to be cooperative, willing to follow directions, and then they have to be continent, contained, so no open wounds or drainage, or if they are, they're covered, and then making sure that they're staying clean, so washing their hands, clean clothes of that sort. And then the part on the right is our policy, a little snippet of the policy, and it pretty much spells out those exact same things. You can see referenced under number 1 are the 5 C's, and it kind of goes into further detail there. So when in doubt, know that this policy exists. It can always be referenced. Our intake department is typically the ones who do the beginning part of this, but you know, it's good for all of us to be familiar with the policy and what that kind of looks like. So just know the policy exists, but then when in doubt, we have done it multiple times too. We can reach out to infection prevention. If there's something a little unique about a patient or we're not totally sure, they are also a really great resource. With that being said, so Megan, like I said, is our newer infection preventionist through the system. She was not able to attend today, but she is planning on coming to an upcoming team meeting just to introduce herself. For those of you who have worked here for a while, you might remember Jen. She was our previous one a couple times ago, and she has come a few times to do like talks on certain infection prevention related items. So Megan very much so wants to meet everybody and have you guys be familiar with her, but she couldn't come today. So we'll plan that for an upcoming team meeting. But if you need anything before that, Christine is our go-to person for BPC, but knowing she works nights, if she's not here and you guys need something, we can always reference policies, reach out to us, or reach out to infection prevention.
Alright, for the CPI movement meeting, instead of doing an actual poll this time, I wanted to talk about rational detachment. So for some of you, you haven't probably done this class in years, at least the main class, so if you're not familiar, rational attachment is recognizing the need to remain professional by managing your own behaviors and attitude. So I think it's something that gets taken for granted a little bit, like we don't really learn about it in nursing school, kind of like what to do when the patients that you're working with maybe don't want your help or are trying to get a rise out of you, or if you're having a hard time. So the CPI recommendations are to observe the behavior. Is there some kind of unmet need here? What is the patient trying to communicate with their behavior? How am I responding? What am I expressing or conveying? And how are they responding to me? So their tips are really kind of simple things, right? Take a deep breath, choose your words carefully, and ask for help. But it's really kind of the idea of understanding that whatever is going on is not personal, it's not about you, and it's a communication of some sort of unmet need or some sort of distress. And then if you go to the next slide, this is a CPI, just a few minute video as well.
Assure you, if there were any spots open, I would gladly have rescheduled for you, but...
Are you stupid? I don't care how many people are waiting. I need to speak with somebody now.
We know that when a person perceives a threat, their brain and body instinctively react to protect them. But the same thing can happen to you as staff. Your brain perceives a threat or a challenge, and it reacts to protect you. Your amygdala overpowers your thinking brain. Hormones are released throughout your body, triggering that fight or flight response. The result? You respond emotionally. Your ability to think rationally and make objective decisions can be overpowered in this moment. If you're not careful, you might find yourself responding in a way that escalates the situation. One reason this can happen is implicit bias. Without even realizing it, we can easily fall back on preconceived ideas or stereotypes about certain people. Factors like implicit bias in previous experiences can make our brains even more likely to perceive a threat. This can increase the chances that we overreact to a situation unintentionally. But there is a way to suppress this fight or flight response. If you can understand this response and recognize when your body's becoming tense, you can take steps to regain control. It starts with rational detachment. This helps activate your thinking brain, preventing your amygdala from taking over. When you understand a person's precipitating factors, remain calm and respond thoughtfully, you're
welcome slide looks a lot smaller than it has in meetings past, and I'm sure you guys feel that as people who do all my training of my new staff. So right now we actually have 3 new staff to introduce. So Emily Hartfield, she's a new intake specialist. She works a 0.4 PMs and a 0.4 knock. Cheryl is an adult unit, all knock shift once she's off orientation, but she's been doing PMs and knocks for orientation. And then Sawyer is already off of orientation. They're fantastic. That is a new VHS we have on adolescent child. And I believe they're actually 0.8 now. I know, okay. Yeah. At first we didn't have that VHS FTE, but PAM. My new hire slide. And then just a shout out to Jessica, Emily, and Holly for passing me on class.
Okay, so an update on the improvement huddles. So for those of you who have been to these in the past, gosh, it's been probably like a year ago now, the system kind of laid out a strong recommendation that we begin improvement huddles. The frequency was weekly, and it's basically the team huddling for 5-10 minutes, looking at the huddle boards on the units, having discussions if there's anything that comes up, and then dispersing and going again about their shift. We started out pretty strong, I would say, doing them, and then they kind of slipped away for a little bit. The biggest feedback from you guys, and then also we felt it too, was that there wasn't enough changing from week to week. So when we were doing them weekly, it felt that we were just kind of saying the same things. We typically review our scorecard, but a lot of our scorecard measures are updated on a monthly basis. Environmental safety rounds, we gather that data on a monthly basis. Like a lot of the things that we were reviewing are done more so monthly versus weekly. At the hospital, they do weekly, but they have a bit more medical equipment than we do. I feel like they, if their pumps are down or there's some sort of downtime they're expecting, they have a lot more that kind of changes throughout. And then on top of that, we are smaller and we typically communicate with each other when there's things that come up, versus putting a note on the board and reviewing it the next week type of thing. So we kind of regrouped, talked about how we can roll these out again, but make them more beneficial for everybody involved. So what we have decided to do is, starting in March, we are going to be just doing it monthly. It'll be same time frame, like 11:30-ish, just because that's more often when the patients are off the unit, or it's kind of a better time versus the busyness of the morning or the afternoon. And then we just ask that everybody attend. We will be communicating the dates when those occur. It'll be either on child adolescent unit or adult unit, and then we'll huddle, we'll go through the board, talk about anything that comes up, and then everyone go about their shift. We did just do one recently, but of course it was a pretty busy shift, so there was just a couple of us in the room. We did it. It's fine, but we know that there's busy parts of the day, and sometimes that's inevitable, and you guys have to keep doing what you're doing. So the one for March already did happen, so there'll be one again in April, and we're encouraging everybody to come. So the first one we just kind of did, but now we'll make sure we communicate it, so like case management and therapy, and we want everybody to just huddle with each other for a couple minutes, talk about it, review it, and then go about their day. There is also a system initiative for leader walkarounds, is what it's called, and that is where the senior leaders go around the units. So our senior leader is Debbie. So basically we're gonna combine the two, and she will be part of our improvement huddles as well. So she'll probably ask you guys some questions. What do you think is going well? What are some improvement opportunities you see? Questions of that sort. But really it's just time to take 5 minutes and talk about what we want to talk about, and then go about our day. So just wanted to share, it'll be a little bit of a revamp. So in April, when I don't know if the date is set yet or not, but when that day comes, we really encourage everyone to attend. Releases. So Jody and I have talked a few times about releases, and I just wanted to give a little information out there. So I think releases are kind of a sore spot for everybody involved. So we are really looking at efficiencies and standardization of how we can make it better for everybody. We have a meeting coming up with legal and compliance, and it's Jody and I, and we're gonna be talking with them about the forms we use. Is there a way to make it easier? Is there a way to make it more efficient? Are there workflows that others are doing that we're not doing? And then also looking at if the records can be sent to medical records versus coming to the unit. Because a lot of times the fax fills up, the unit staff are separating it out, and the providers may or may not look at them, and then they're scanned. So just, those are some of the ideas that we've kind of thrown around. But like I said, we have that meeting coming up, and we'll share as we learn. And then just a little plug about the disclosure notification form. So this form is really important. It's used by all areas. So please just make sure that when they're being filled out, that they're filled out in totality. So we've noticed there's some that have missing witness signatures. There's some where the patient signs, but their parent is also supposed to sign and they didn't, or the patient didn't sign, etc. So just know that form is super important. So if you have any questions about the form or anything, just ask. But just wanted to throw that out there. So not a major update, but just some of the things that we're working on, and anything that we learn, we will communicate with you guys when time comes.
One thing with releases, make sure that the patient is dating and timing them. Willow Creek especially will not accept them if they are not dated and timed. So then they're sending them back to us until we do.
And I'll say too, the disclosure notification form that Jenny just mentioned, for anybody that doesn't know, that's the one where we put like patients' family members' names. They've got the 4 spots to put family members' names. That one is super, super important to me personally because we use that when we're calling family for like collateral. So if you could really make sure that that one is filled out with the patient's signature, our signature, parents if needed, and the date and time, because I think the last 10 collateral calls I've done, I've had to redo that specific release like 9 times. So if you could just really make sure that those are filled in, that would be amazing.
Net promoter score. Jody, are you covering this one or are you not?
I am not.
Okay. Diane did this slide. So it's the graph for our net promoter score. It looks like it is for inpatient. It looks like we're above the average, so you can see kind of where we've been trending. I know Diane has shared this previously, but it all depends typically on how many responses we get. So if you can see, we've kind of been up, down, up, down, up, down. And it looks like the most recent from January, we are up and above our target. I apologize, I'm not prepared to give you the exact number that it's at, but you can at least see how we were trending. Labor management, so just a brief slide here to talk about labor management. So our system as a whole has really set a large goal in making sure we're focusing on labor management, that we're not overstaffing, that we're just being really mindful with our labor. So the unit, I know we have like our ratios, we have our LOAP process, and we've shared that. Debbie has had to report out on how we're doing and our different workflows that we have in place, but just wanted to throw it out there. So we will continue for the units to staff appropriately during our shifts, follow our LOAP process. Something to be mindful of is we know that we have those days, I feel like especially on adult unit where adolescents too, where we'll randomly have like 10 discharges. Feel free to send people home kind of as the day goes on. So we might start the day with 20 patients, but half of them go home. Feel free to hand off your staff or your patients to the other people and send staff home as that happens, instead of everyone ending their shift with like 2 or 3 patients. Same with like support staff, if the day is wrapping up, acuity is okay. We look to our charge nurses really to kind of make those decisions. If there's not a charge nurse, the unit staff can talk amongst each other and make those calls, or, you know, intake, TFs, everything like that. But it's just something to be extra mindful of. And then the last thing is, we know, for those of you who have worked a summer here before, our summers are typically lower census. So if there's anyone who's interested in cross-training to any other departments, that would be a good opportunity too. I know we have one staff member who wants to cross-train to the NICU, and I did reach out to the NICU and they are good with that. So that employee will be cross-training over there during summer. It's just a good way, again, if you've worked a summer before, you know that there's usually more low abs, and we just have a lower census. It's just how we trend. So if there's anybody who's interested in cross-training anywhere, put it on our radar. We can see if we can make it happen, type of thing. So.
Alright, this one's me. Do you want to play the video?
Do it flat thing.
Grammarly now uses AI to help you write, not just revise. Type prompts and generate.
Hi everyone, Linda Galley coming to you with another Civiltas message. So this month, we are talking about giving and receiving feedback. How difficult that can be sometimes, right? To give feedback or receive it. And so we really want to say, can we talk about it? Here are going to be some ideas and some tips so that we can work on giving and receiving feedback, because if we really are going to have a transparent and psychologically safe environment, we should be able to have these conversations and to be able to talk to each other. So here are going to be some kind of general ideas on what you can do when you're giving feedback. So remember to be as specific as possible with the behavior. It helps to give something specific, because then people aren't wondering what you really meant, and hopefully you can have a conversation about it. Keep it pure and straightforward. Don't kind of beat around the bush per se, but just be really honest and straightforward about it. And of course, people can always tell your tone when you're coming at it from an honest place as well. Make sure you're using only first-hand information. You know, this isn't something where we want to take hearsay or stories that we've heard, but we want to be really looking at, is it something that we've personally experienced, so that we can speak to that. It also helps to use really neutral, non-judgmental language. So it's not good to blame or label things, but rather just stick to what you've heard, what you've seen, really keeping it more factual. And make sure you're giving that feedback immediately. Don't wait several months where it's not going to be fresh in people's minds, but maybe address it as quickly as you can. As well as giving feedback, sometimes we need a little improvement as far as receiving feedback. So we have to remember that none of us are perfect, and I know myself, I don't always like to hear when I'm doing something wrong. But if I take that and take it to heart, I really do have an opportunity to improve and maybe do something better than what I've done in the past. So really two big things, if you're taking feedback from someone, focus what you can do as a result of that feedback. Maybe take a moment and reflect on it and think, well, is this something I can change or I can improve on? And talk to other people that care about you, and maybe kind of brainstorm with them on what you may be able to do. And remember, the goal of feedback is not to make you feel bad, but really just to help you improve. So we hope you have some really good conversation with your teams this month about this topic. If you have any questions or want to give us any feedback, please email us, civiltas@bellin.org. Thanks so much, everyone.
So this slide pretty much just recaps everything she just said. I just put it all on there in case we want to watch the video.
Culture of safety. So previously Diane was our safety, I don't know the term for it, safety person, and kind of oversaw some of the different aspects of safety at BPC. Recently, the nursing leadership team kind of took this under and wanted to just give a little information and then also get any feedback if anyone has any. So I think it was 2 team meetings ago, I had shared some of the results from our Prescani survey. And one of the common themes that came across in that survey was that staff felt that we needed to do a better job in prioritizing a culture of safety. So you'll see in our weekly updates that Debbie sends out, there's a little culture of safety section. We want to make sure that we're working towards that and listening to your guys' feedback and prioritizing a culture of safety and seeing what we can do better. So, like I shared, there's the culture of safety part of that email, and we'll try to do a better job on highlighting some of the safety work that's being done. An idea that came up is a possible survey. So we really want to hear, for those of you, I know the Prescani survey was a while ago and the next one will be here before we know it, but if you felt that we weren't prioritizing the culture of safety as a whole here at BPC, if there's any like examples or things that you think we need to do better, if you're willing to share it with us, that would be great. Otherwise, we did throw around an idea of possibly putting out like an anonymous survey, Survey Monkey, I think they're called, to just get more information on that. So that may or may not be coming, again, just an idea. But if there's any opportunities you feel that we have or certain safety aspects of BPC that you feel are not being prioritized, we just really encourage everyone to speak up about those things. Some of the things that have happened just in the last month or a couple months here that talk about safety a bit. So we did do a root cause analysis on a medication exchange between patients, which Danielle will talk about shortly. We did implement code button audits, so security actually owns that audit, and they will be testing our code buttons. As you guys know, I don't know, about probably maybe 6 months ago or so, or even a little longer than that, we corrected the delay that we had, but we had a pretty significant delay for quite some time from when you hit your code button to when it would actually alert. So that has since been corrected, but to be proactive with it, we did create, or well, security is owning it, a code button audit, so they'll make sure that they're testing them pretty frequently to make sure that that delay doesn't slowly sneak back in, because that's kind of how it happened. We didn't realize it, and then suddenly we're like, that seems like it's taking a long time. So we want to make sure we're on top of that. And then along with that too, as you guys know, like over there in the corner and other areas of BPC, we have the wall-mounted code buttons. So that helps ensure that we're testing those regularly too, because we might not push them frequently at all, but when the time comes, we want to make sure that those are working too. So that is something security owns. They will be initiating and they will be reporting it out at our safety and quality meeting. 15-minute check audits, Danielle will be talking about shortly, so I won't cover too much on that. And then, as you guys know, our environmental safety rounds, that's kind of a big thing we always track. Katie collects the sheets at the end of each month and tallies them up and looks at how we've been doing. And then recently we started tracking the work orders associated with them. When D&B came the last time, they asked us, you know, you guys are doing this great work, you're tracking, you're finding things, but how do we know that they're being corrected or that work requests were submitted? So Katie has been working with our facilities team, and they have a process in place to where they'll be kind of comparing what work requests have been put in, when they were completed, that sort of thing.
That also allows me to put work requests in if ones weren't put in for them.
Yeah, just to make sure we're covering all our bases. And then safety and quality meetings, I feel like I've shared this a few times, but just we'll throw it out there again. This is a very specific BPC meeting, and we really focus on the safety of BPC and quality, hence the title. But we talk about med errors, there's security updates, if there's any previous patients we've had who have attempted or you know, anything like that, we review those sorts of things at this meeting. And then any upcoming recommendations, the root cause analysis, it really is a meeting to just specifically talk about safety and quality of BPC. We are always looking for more unit staff to be part of that. So if there's anybody who wants to be, we would really appreciate it, but just wanted to throw that out there too, because it all has to do with the culture of safety at BPC. So that is it for that. Like I said, if anyone's comfortable sharing any thoughts that they have or how we could prioritize it, you may or may not be seeing a survey come out in the near future, but we at least encourage you to share with us what ideas you have, because safety is very important here, so we want to make sure we're prioritizing that.
All right, so annual internal audits. So Jenny prefaced some of the work that we do that was approved and goes to that patient safety and quality meeting are our annual audits. So currently we have 4 different processes or workflows that we're auditing. One of them is post-fall huddles, completed within 24 hours. So everybody knows I'm going to come looking for that post-fall huddle if somebody calls, right? But my goal is to make sure that it's completed within 24 hours and then that it's appropriately scanned and we're able to identify any gaps so we can close out our meeting. So making sure that we have those within 24 hours. So I have a spreadsheet of all the falls and I document, yep, it was done on time, no it wasn't, and doing like individual feedback and follow-up, things like that. Another process that we audit is discharge 7-day and 30-day follow-up appointments. So Diane and the case management team own that one, and so she follows up to make sure certain patients, if they have the post-discharge appointment within 7 and 30 days of discharge. And then another one is a random 15-minute check audits. So we instituted the random 15-minute checks on all patients. When did I say that was? I don't remember. Several months ago. But when we started the new process, how do we make sure that we were following that process? We changed our policy and basically I go in and audit 30 charts a quarter or 10 a month to determine was there at least I pick a random day of the patient's stay and I look to see if at more than 50% of a 24-hour period the checks were done randomly, meaning not at the top of the hour, 15, 30, and 45. Now I understand that if you're doing things randomly, at some point it will land on those times, totally fine. But as long as I'm just making sure that we're not doing day after day of everything on those quarter hours. So on the bottom here, just taking a look at kind of how we've been doing. Our goal is obviously going to be 100% because that's what is compliance with our policy. We want to be doing it all the time. But we've been hovering the last 2 months right around 80%. So as a result of some of those audits, I will be doing individual follow-up if I notice any patterns as far as any particular person that's maybe not doing it consistently, someone who's doing a really good job. I might ask them if they can help work with someone else. I know it can be really difficult to like go and figure out, okay, when was a 15-minute and then I finish all these checks and you gotta start all over again. I totally understand that, and again, I'm talking about project fusion and some of the efficiencies that we hope to gain with that behavioral health module, being able to do it on an iPad would really be helpful. It will be a manual process. It would fall basically on a document where everybody's in order and the patient drops off and to the bottom of the list as you go. So that would definitely be an efficiency for us. But for now, we're still on paper, so just making sure that we're following our policy. So if I come and talk to you about that, it's just to try to make sure that we're being more consistent with that. Overall, we've done a really good job since I first started doing them. I did audit them prior to the change of the fiscal year, and we were hovering more around like the 40% range, so we've really done a good job. But trying to get to that more consistently being done on every patient all the time. And then Jenny mentioned the code button enunciation timing, making sure that that timing is appropriate and what we expect for a product that we've installed in this facility for your safety. So those are some audits that we're doing regularly, again, just to make sure that we're in line with our policies and procedures and safety for our staff and patients. Anybody have any questions about those? Okay. Next thing is the RCA follow-up. So RCA stands for root cause analysis. So we did complete one of these following the incident at the end of February where 2 adult patients were able to cheat and exchange medications. And this resulted in one of the patients required admission to the main hospital. So in looking at that process, and with some diligent work from the staff with regards to talking with the patients, researching them and making sure that they were safe. In the meantime, we were figuring out what was happening, as well as the leadership team that took part in working with the individual patients to determine exactly what process occurred. We were able to determine that there is a gap in our medication administration process, and that revolves around mouth checks. So historically, we've always done mouth checks on child adolescent